Good afternoon. First, I would like to thank the organization committee for giving us this opportunity to present our ideas. Terry and I proposed a pilot study for data harmonization and the rare variant detection among the international cohorts. Sorry, Jeff, we still use data harmonization. Okay, we all know that multiple genetic and environmental factors, some of them we know, but most of them we don't know, affect the population health. Ancestral population which lived in the different geographical location, and they're all exposed to different environment that include the cultural environment, the physical, psychosocial environment. So because of this, the genetic the health disparity among different population across the different countries. International cohorts give us a great opportunity to study the both genetic and environmental factors associated with population health, and the population also have a different genetic ancestry, also live in a different continent or countries. To do so, they developing the effective methods or approaches to combine and utilize this cohort data is critical. Therefore, we propose to a pilot study to examine whether or how the international cohorts data can be combined and utilized for global health research. To do so, I'm sorry. Okay. Sorry for this. Okay. To achieve this goal, we proposed 4 specific aims. First, to standardize and harmonize the cohort datasets to perform combined analysis. Those datasets include the demographics, clinical phenotype or conditions, and the genomic data. For genomic data, we propose to impute the existing genomic data, include the array data, and we also include the whole exome sequencing or whole genome sequencing data. For the performing the whole genome sequencing, consider that we have underrepresented population, so we'll do the whole genome sequencing among underrepresented population. The specific M2 is to achieve the. We expect that the participant cohort to collect the high-level environmental data, such as the weather, like the yearly or seasonal run temperature or humidity range, and the air and the water quality, location efficiencies, such as the residential population, employment density, and the jobs per house unit, and also some road density, and finally, the hospital accessibility. The third specific aim is to compare the frequency and the distribution of genetic variants among cohorts and the different ancestral population. The focus is on, since we started pilot study, so we focused on the loss of function variants, clinical actionable variants, and the pharmacogenomic variants. The fourth aim and the last aim is to identify effects of rare genetic variants on disease or clinical phenotypes For the pilot study, we propose to include breast cancer, post-cancer, diabetes, HIV infection, and hepatitis B or C infection, given the significant different distributions of those diseases across ancestral population in different countries. We expected that the participating cohort can share harmonized data and utilize them to compare the different distribution of genetic variants and environmental factors across cohorts, and to assess their effects on selected disease in different populations. To conduct the pilot study, first is to identify participating cohort during this summit or sooner after this summit. The following agreements are needed from participating cohort: share de-identified data, provide basic data elements, including the demographics, clinical phenotypes, provide biospecimens, blood or DNA for sequencing as needed, provide genetic or genomic data, as I mentioned before, for array data or sequencing data, collect and share the high-level environmental data I presented before, and collaborate in the data standardization, harmonization, and analysis. As I said before, considering the lack of genetic information from underrepresented populations, it might be necessary to identify underrepresented population for whole genome sequencing. Those cohorts needed to provide biospecimens, agree to share their data with other cohorts, and agree to ship samples to a sequencing facility. The genome-wide sequencing might be conducted in 3 to 5 cohorts with around 2,000 samples from each cohort. The pilot study do need the help from teams A and C for the data harmonization and the utilization. We propose to have a federated data system for data sharing and analysis. Team A will lead the development of data standard procedure. Data standard protocols will be distributed to participating cohort for data harmonization. Each participating cohort will operate their own data repository. Investigators can access all participating cohort data for data analysis through a system of workspaces. Team C will lead the development of data accessing policy. A participant cohort can use all this data in the federated system only after their data access requests are approved by data accessing committee or steering committee, after they sign a network data access agreement. They can analyze the data through a system of workspaces, but cannot download any datasets from the data repositories. If investigators are interested in datasets that are not in the federated system due to a specific data sharing restriction, in individual cohorts will analyze their own data and then provide the study results for information aggregation. In terms of timeline, we propose a 3 years study for this pilot. In the first 2 years, the focus is on data harmonization, additional data collection, such as environmental data, genomic data imputation, and the sequencing as needed. In year 2, investigators should complete the data cleaning and the data analysis. In year 3 is for dissemination, include the results, interpretation, publications of preliminary results, and the lessons learned. The estimated budget for this 3-year pilot is about 18 million US dollars. This includes one coordinating institution with about 750K total cost per year for 3 years, and 15 to 30 subcontracting institutions with a total of about 3.2 million per year for 3 years. Sequencing cost about 6.4 million for about 8,000 samples with about 800 per sample cost. This is all about our idea. Thanks. Now we open for questions and comments. Terry, if I missed anything?
All right, we've got maybe time for one question, if there is one.
Yes, Jim.
It's not really a question, just a comment that what you propose seems like an overarching framework for many of the types of studies that the consortium might consider. So I thank you for providing a great outline for some of the things we're probably going to hear about in the next few hours.
Thank you. Yes.
Oh, sorry. Go ahead.
Go ahead.
Just small comment, because when you combine all the cohort data, you know, we may have to see their guidelines, because for same question, the guidelines might be different. You know, so even for example, tobacco smoking, the definition used for the current smoker may be different for the different cohorts. And I think we need to compare even the guidelines which is proposed by the different cohorts.
That's a very good comment. Yeah, that's what the team A will help us if this be funded, and help us to standardize all this measurement. Then develop the standard procedure, then the protocols distributed to all these subcontracting or collaborating cohorts. They will put the standard variables there. Then we hope to reduce as much the measurement error as possible.
Yep. Terry?
Terry Manolio, NHGRI. We might just note that this presupposes a fair amount of infrastructure already being built by the time, most of it by Thomas, but by Team A, and then and then the policy aspects by Team C. So there would be a fair amount of work to do before we could do this, but one could get started on this and have it be a driver of some of those efforts.
Great.
Yeah, exactly. I mean, this is like the kind of like the application if the infrastructure of IHCC exists, and when Team A delivers all the things they're going to deliver, basically what could be possible essentially with that infrastructure. And these are the ideas that we need to have. All right, great. Let's move on then.
Great, thank you.